Hello,
Welcome, Dr. McMorrow.
how are you, Elisa? And I know Tim and everybody. So I don't know if you want to I understand this is kind of a question and answer session. So
Yeah.
um, I didn't know if you wanted to kind of had any questions about MOUD or anything specific. Just a little bit about me. I'm an emergency medicine physician. I did a residency in that, and then I did a addiction fellowship. Um, so I'm double boarded in that. And then we run a SUD clinic here up in Houghton Lake, and we're pretty busy. We have about almost 300 patients. I'm also the one of the directors at Bear River Rehab and Detox, and then I work obviously with the MOC as a consulting physician as well. So we appreciate your time, and let me know if you have any questions or kind of what you want to get into. Um,
Questions. So first of all, I visited Mid-Michigan Health for my first time a month ago, probably as Suzanne did, because that's where we were able to get our first Fauci ouchie shot. And we're due to get our next one tomorrow. So we'll be back there tomorrow. That's
oh,
quite the
great.
campus. Yeah.
Yeah.
Um, when you got your clinic there started at Mid Michigan, can you tell us kind of some of the maybe trials and tribulations that you faced? Because that goes right in with the stigma.
Oh, sure. So I think the biggest part when we first started was kind of um, educating kind of the surrounding community on what we started doing, as well as the pharmacies and the administration and kind of what the basic kind of harm reduction and what we're planning on doing. We started from the ground up, so we implemented all the policies and we started, with a good approach as far as the milieu of the office, everybody's overall perception, and kind of just had some educational things before we got up and running. And we talked about, use of language and how difficult it is for a patient to even come in the door and things like that. So we took kind of a harm reduction approach and just basically, to answer your question, just educated the staff, educated the surrounding pharmacies on, the the goal of treatment and our gold standard of treatment is to use medication for opioid use disorder. So once we kind of set forth educational with the community and the pharmacies, we've really got great feedback. So
You didn't get any pushback from like local government or, you
none,
know,
none at all. We also reached out to the courts and surrounding police um, police stations or jails, and they're on board too. So we try to communicate, especially with Roscommon and their judges. We brought them in and had a good question and answer session, and then we also provide. They let us, provide MOUD for individuals as well. So
oh, in the jail.
yeah. Mhm.
Oh, sorry. Apologize.
Yeah.
Um,
And real quickly, so what is your position and where are you located?
So I am a certified prevention specialist with Catholic Human Services. You probably know my good friend Joe Jean, that's very active there. I think Mid Michigan, that's Ogama County. Is that right? Or is
We are
that
we are Roscommon.
County? Okay, I still think that's her. I'm pretty sure that's her county. Yeah, Catholic Human Services covers 21 counties, but we only have prevention services in 14 of them. And I actually cover Grand Traverse, Leelanau, and Kalkaska. But I live in Kalkaska and have for going on 20 years now. Um, Although I'm originally from Traverse City, and I noticed I used to work for Michigan Works in the youth services program. I was in charge of it, and probably, oh gosh, I don't know, 10, let's say 10 years ago, when I started to be able to count, on more than one hand, naming names, young people that were dying from overdoses,
Mhm.
and that's still when it wasn't widely talked about. It's like, something's going on here. We got a problem. And then of course, everything finally blew up and just weirdly ended up in this job that I'm very passionate about. But I'm the chairperson of the coalition, and Suzanne is my coordinator. She did it for about as a volunteer for years. And I said, let's write a liquor tax grant and get you paid because, you know, you do so much. So here we are today. But yeah, the jails. I mean, so you heard Suzanne and I both live here in Kalkaska County, and you know, Kalkaska is kind of a entity unto itself. Better you know, it's a very interesting mixture, both of culture and politics and everything else. So we're working hard. That's why I'm going to pick your brain on, okay, how, you know, what's the best way to do that education to you know, the old fashionedness and the stigma of things like medication assisted treatment that we still get, that oh, that's just replacing a drug with another drug, and da, 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 and other things that are horrible that I won't even repeat that I've heard in my job. How, you know, how do you get through?
Yeah, so that's a great question. And what I do is I try to get myself or somebody who has knowledge of the, the new guidelines in front of these people. With knowledge comes behavioral change. So I'll present, one of my presentations. I'll just show you some of the new ASAM guidelines that came out with some pretty strong language. And I highlight that and I tell these guys that at these meetings. So let me, can you see my screen?
Mm,
Now we
sorry.
can.
You can see it.
There it is.
So, yeah, the ASAM came out with these new guidelines, and I put this, in front of them, and we know that, I just took it right from the new guidelines that came out last year, and I'll read this to them. That we know that providing methadone or bupe, even without psychosocial treatment, is the standard of care, and they came with these strong recommendations, including individuals with OUD within the criminal justice system, and that's them bolding this, should receive the same standard of care as individuals treated in the community. This means that all medications for treating OUD should be available, and patients with OUD should be allowed to maintain their current medications in the criminal justice system. So, I read these statements and we talk about this, and then, we talk about harm reduction, but then, they'll say, and then these myths too, that they also say, methadone and bupe do not substitute one addiction for another. And we'll talk about that. And then when they talk about diversion, we know that this is generally uncommon, and it's less than 1% of all reported drugs diverted in the United States. So we have a kind of a back and forth, and we know, kind of what the answers are, and we try to dispel those myths as kind of tactfully as possible, and just kind of educate them and provide knowledge and go from there. So that's kind of what I do, and it's worked out pretty well. So I always say too, if anything from just behavior, these patients are going to make it a lot easier on you guys in jail. They're not going to go through withdrawal. They're not going to act out, So, and then they look at that and they're like, oh, okay, well, if that's easier, then maybe. So
Sure.
it reduces.
I think, and not that this should be the ultimate reason why, excuse me, they want to jump on board with it, but I think sometimes for some people, particularly as you were describing, Lisa, that maybe are a little more old school, is the cost savings. One of the things that we talk about in some of the presentations is that the medications have been shown to reduce costs. The fact of the matter is, people getting sick, people overdosing, people dying is incredibly expensive. And the amount of time that can be saved and money that can be saved from a resource standpoint, whether it's within the hospitals or law enforcement themselves, they're not going out to scenes where people are overdosing and having death. If they're on this medication, can help reduce that. And we've seen that some of the times I've talked with law enforcement, that that's kind of the point that kind of catches their attention, that, hey, I'm not going to be going to these types of scenes anymore. My time can be spent elsewhere, which again ends up saving the county quite a bit of money.
So Dr. McMorrick, you said, and maybe I misunderstood, your SUD clinic. So does that cover alcohol use disorder too?
Yeah, we try to treat, regarding everybody who has a substance use, whether it's alcohol, opioids, benzodiazepines, sedatives. As long as, we can kind of appropriately treat them here, we do, at least, try. A lot of times they'll have to go to detox or something if they have a severe alcohol use disorder first. But also we're kind of rural and wilderness medicine. A lot of them won't go to a detox because it's an hour and a half away.
Right.
So we do what we can. But to answer your question, yeah, we treat alcohol use disorder.
Are you seeing sort of multi substance disorders where folks are addicted to maybe both opioids and alcohol?
Oh,
Or
absolutely. Yep,
yeah, okay.
very
And
common.
in a training I was in recently, actually, and I was being trained to do presentations and there's so many prescription medications now to help with withdrawals and with treating substance use disorder. It's hard to keep up between the brand name and the actual chemical compound name, but I'm old and I used to be in the army, and the army was very fond of and abuse when folks had alcohol use disorder, which was probably about 75% of the whole military, believe it or not. But and they actually used to, I was an enlisted person and my first husband had alcohol use disorder and they prescribed it for him, and they would make, soldiers go right in front of their first sergeants to take their antabuse to make sure they took it or whatever. And I saw in this training that I was in that is still somewhat being used, but I'm real curious because I got it actually was a drug rep, of course, but Vivitrol, because a lot of law enforcement guys were really saying Vivitrol was going to be the be all end all because, it didn't have any capability for abuse. They thought, for and this was my Leelanau County sheriff, who was really taken with Vivitrol, but the price was very high, and so not a lot of folks could use it. I mean, what's been your experience with Vivitrol?
So that's a great question. I do use Vivitrol quite often. It has to be kind of the right patient, depending on a lot of so I guess I break Vivitrol into two things. So it can be used for opioid use disorder and alcohol use disorder.
Right.
I have a lot of patients on it for alcohol use disorder. The studies do show the number needed to treat. We're not looking for abstinence. Basically, it's to decrease the amount they drink when they drink and the number of times they drink. It's not going to cause them to get sick or anything like that. It just kind of decreases that dopamine tone. So when they do drink heavily, they don't feel as good. It doesn't have great, I guess, studies or great efficacy with drinking. And even with opioids, studies show that high, I guess, functioning individuals, somebody like who's really doing well in their work and they know they can't, relapse, and they know they have no other options or they'll get fired and they're in heavy scrutiny. That's when the Vivitrol really works for opioid use disorder. The problem with Vivitrol is it has less of a people don't come back as often, and they'll just stop taking it and stop coming. So the retention of treatment kind of really goes away after 3 to 6 months. So you don't have that reinforcing effect of the Suboxone or methadone where they'll, get withdrawal or they can't just stop it. So I would say it's less useful in a lot of individuals with opioid use disorder and retention of treatment. And all the studies show that, you get the reps and things will say, oh, well, it shows similar efficacy with bupe or methadone. It doesn't. If you dive into the studies and really look at it, it has retention of treatment is a lot worse. And so it's all individualized. There are some few that do very well with it. I would say the majority don't. And they'll have to bump up to bupe or methadone.
What about the Sublocade?
Yeah, so we are having really good success with the Sublocade. I probably have maybe 10 to 15% of my patients on Sublocade. And again, that's individualized treatment. It depends, you know, usually my patients that are stable, that, you know, are ready to get out of the hand to mouth kind of part of the addictive process. I usually will get them on Sublocade. They're kind of sick of, you know, taking something every day, or they're more stable. I find that they do better. The patients that don't do very well are the ones that are really unstable. They still have to take something, and they'll just kind of, you know, they'll just kind of go bananas if they're not taking something every day. So that's kind of my experience with that. And then also I'll put patients on it that kind of want to taper down off their buprenorphine over a long time, 6 to 12 months, because we know when we get to a steady state of Sublocade, we have a consistent level of the buprenorphine in your system. And we know through studies that if they stop taking it, that up to 6 months to a year, they'll still have buprenorphine in their system. So they'll slowly taper over months to a year and don't get any withdrawal. So, yeah.
So what would you recommend for, because there are people out there that do misuse these medications.
Yeah.
What would you recommend for them?
What do you mean by misuse their
Well,
medications?
I know certain people that might take like a quarter of a strip one day and then, save it up and take more than they need the next day, or they're trading or selling, or would you say about that?
Yeah, I mean, again, I always say, you know, there's always, you know, people are going to do what they do when they leave your office, right? We're not detectives. We are providing a medication that is now standard of care for opioid use disorder. You know, we can only do what we can do. Um, and patients, once you get to know them, and I'm sure Tim can talk about this, once you get to know your patients and establish a really great relationship in recovery, and, you know, they understand, they'll tell you everything. They'll say, Doc, you know, I'm not, you know, that 3 a day, you know, that was just when I was relapsing. I'm good now. So it's all about relationships. It's all about, you know, gaining trust in your patients. And, you know, these incidents that you talk about, or trading here, they're a lot more rare. And, you know, I always say it is what it is. I mean, what can we do? I can't follow the patient home. I can't, you know, so I guess to answer your question, I always talk with them, gain knowledge, try to gain their trust and support in their recovery, and give them what I can.
Would the Sublocade be better for someone that misuses like that?
Sure. Yeah. I've had a couple patients, and they'll tell you, they'll say, I ran out early. I was taking 4 a day. I was stressed. I was like, I know if I have this medication, I'm going to take it. And I'll, you know, first I'll say, all right, well, give it to somebody, give it to your wife. She can hand it out to you. Or what I'll do is, you know, I'll only fill them for 7 days with 3 refills. So they can only have a certain amount. So they have to go back to the pharmacy every week. But if that doesn't work, they'll tell you, you know, I can't have it in my hand. I know that I just will, you know, take it wrong or won't take it. And those are really good patients for Sublocade. So that's a great question.
Right. As far I know that there are some clinics that use the medications for opioid use disorder for meth. What's your thoughts on that?
Um, well, just in a broad statement, I guess, we know that there's no FDA approved medications for methadone, for stimulant use disorder. I would say I don't see a lot of supporting literature to use, you know, Suboxone or methadone for meth use disorder. We have seen a study which uses Vivitrol combined with Wellbutrin, for meth use disorder, but the number needed to treat is 12 or 9 or 12. So every, you know, with good results, you need to treat one patient. With good results, you need to treat, I think, 9 or 12 patients. So it's not great medication. Where the number needed to treat with bup or methadone is about 2 to 1. So yeah, we're in a tough situation right now. A lot of people are trying different things off label. You know, I've tried things like Wellbutrin, Remeron, Vivitrol combined with Wellbutrin, N-acetylcysteine. Um, so I guess, and a lot of these are co-occurring. So they'll have an opioid use disorder with a methamphetamine use disorder. So if you stabilize their opioid use disorder, maybe with on Suboxone, and use the counseling and the psychotherapeutic approach and the 12 steps, or, you know, IOP or whatever else you can use, you know, then you have a shot in retention of treatment. So it all, you know, it all is how they're doing in recovery, I guess. But to say somebody that has only a methamphetamine use disorder and to use a Suboxone or methadone, I haven't really done that.
I was just wondering because they have, obviously their dopamine levels are low using, the stimulants as well.
Right.
So would it raise their dopamine using something like a Suboxone?
Yep. Yep. And they have done some studies on that, and nothing's really panned out. But it is a little different mechanism with the opioid receptors and the different catecholamines. So it's definitely a good question. I don't think I think they're getting together like a stimulant use disorder recommendation and developing a panel with ASAM. They actually emailed me to see if I'd want to be involved. So it's coming, and the studies are coming. Um, so it's It's going to be interesting to figure out what we can do for sure. And there has to be something. I mean, I'm seeing it all the time. And when somebody has an opioid use disorder with a stimulant use disorder, I never take them off their Suboxone ever. I'll even sometimes increase their Suboxone because they're just saying I'm craving everything. So we kind of use just an approach, and we see what we can do. So it's tough though. It really is.
Um,
Dr. McMorrow, when Timothy brought up money, and these days, I'm very sarcastic, and it was like, oh yeah, there's money these days in opioid use disorder. It feels to me like the government is just throwing lots and lots of money around to solve the problem without a real super strategic approach. And when you throw money at one area, then like we were talking about stimulants, then another area grows larger again. For a while we had stimulants sort of kind of pushed down under control, and then the opioid epidemic broke out, and then you get a handle on that and we go back to stimulants again. um
Exactly.
for So in my roundabout way, as I'm thinking out loud here about money, one of my pet peeves is the whole insurance deal. um would you say most of your patients are Medicaid patients? Because it feels like to me that if you have Medicaid, you're in good shape. But if you have private insurance, you're kind of screwed. It doesn't, a lot of things aren't covered, and that bothers me. So I just wondered if, that's your sense also.
I echo that. I would probably say 85 to 90% of my patients are Medicaid, and everything's basically covered for them. And the private, payers have to pay a lot more for their medications and things like that. So, and even if you want to go to rehab or detox, it's crazy if you're a private payer or don't have Medicaid. The barriers are so much more. So,
Yeah, yeah, yeah. Hmm. Well, I don't know what we can do about that, but it's something I guess to be mindful of when you vote and you talk to your congressman.
absolutely, I think it's crazy.
What
Um,
percentage of your patients do you believe have co-occurring conditions like anxiety, depression?
I think I would offhand, I would probably say 60 to 70% of them. Absolutely. And that's usually, the average too. Whether it's a mood disorder, anxiety, depression. But then the hard part is kind of figuring out what came first. Is it a substance use induced mood disorder, or did they have that prior? So yeah, we see quite a bit of it, and I try to treat it as part of that psychological approach to addiction. Biological, psychological, social, and spiritual, and we try to do all four things and really kind of hit everything. And we also try to integrate the 12 steps. And recommend it. I'm not saying it works for everybody, but we try to pull everything, to gauge and give support in their recovery. So.
Do you feel most of your patients had the condition prior to the substance use?
Um, Most meaning more than 50%. I would say probably yes, maybe around that, half of them. Yeah.
so I'm going to ask a question kind of a personal nature. My younger sister died 2 years ago as a result of her alcohol use disorder, but she also had an eating disorder, and she had had bariatric surgery probably, I don't know, 10 years ago, let's say. But I'm seeing more and more stories that, especially with women that have bariatric surgery, that there's starting to be a real connection between SUD and, you know, have you read anything? Have you seen that yourself?
I have seen that, and I listened to a lecture on it last year. It's usually about a year or two after their surgery, they develop this, um, and especially alcohol use disorder. And I'm not really sure why, but that was when I was studying for my boards. They talked about that. So it is interesting, and it's interesting that you saw that. And what have you read about it?
Well, it's kind of a new emergent thing, and once again, I'm a pessimist. So, for a while, there were lots of bariatric clinics popping up all over the place, and it was the newest and greatest thing. And, my personal opinion is, although they're supposed to do a psychological screening, first of all, it's pretty easy to get through that. And so I'm not sure that that was as much as it needed to happen with her, because she had been bulimic since she was probably about, I don't know, I guess 15, let's say. And I asked her when she said she was getting the surgery, I said, "Did you tell them that you've been bulimic most of your life?" And she's like, "Oh yeah, yeah, they said it's okay." And it's like, you're gonna have major surgery. So um so I think, just in my own personal experience, I had some questions about how well they did that piece of it. But then, weirdly enough, here in Kalkaska, another friend of mine, her sister died almost the same way that mine did, had bariatric surgery, and then, really, she did both alcohol and prescriptions, and then went to illicit um, heroin. And but pretty much died the same way. And it just, the comparisons, it's like, God, that can't be just coincidence. And so then I started looking into it and found that, yes, we're seeing more and more of that, but I'm not sure it's getting noticed, but I'm not sure it's getting studied or really talked about as far as how do we treat it, now that we know it's definitely, our patients that are getting bariatric surgery getting um, uh, the information that this is a possibility before they get the surgery. I don't know. So,
Yeah, that's a good point. And I don't know if anybody's reached out to the bariatric, society or anything like that, but it is getting, I think from the addiction world, it is getting noticed. So I'm not aware of any studies that are going on right now, but like I said, with that lecture that was just this past year, um, it was in there and talked about. So
well, good. I, once things are starting to be talked about, that's the first step, in my opinion.
yes.
Um, I had another thought too that came in my head. Now I went right back out again. Go ahead, Suzanne. I know you got something.
When we go to adverse childhood experiences, you hear a couple of different things. When you look at the ACEs study, it shows that everyone who has a substance use disorder has a high ACEs score. And then you hear other things that not everybody who has a substance use disorder has had an adverse childhood experiences. What's your thought on that?
Um, well, I would say as far as the ACE scores, most people that do have a substance use disorder have some kind of ACE score. Um, I would say there are exceptions, and we know that, genetics plays a huge role, especially when we get, so nature versus nurture, the nurture really starts in childhood, but the nature, when you get past 18 and into early adulthood, that's when the genetics really kick in. And we know that through studies. So if you have, a grandparent or a father who has a substance use, you get these epigenetic changes, and you can really develop that even without a poor childhood or something like that. So you see that genetic component really take off in adulthood. So you'll see if somebody who has a normal, great childhood and normal development, and then you're talking to them, you're like, what, kind of why, you had a great upbringing and, everything was great and no aces. And then you look at their genetics and they really didn't start till later, 20s and even mid 20s and 30s. That's when their genetics kind of popped in. So that's what I see.
You think that someone that starts using at a later age, it's easier for them to go into recovery than someone that starts at a younger age?
That's a tough question, Suzanne.
The length of use.
That's a good hypothetical. I don't know. Ask me that one more time. Sorry.
So if you have like a younger person that starts using at, 13, 14 years old, um, would it be harder for them to get into recovery because changes in the brain as they use than say someone that started and developed their substance use disorder at 25?
Um, I guess in theory, because they could possibly have more brain changes before, maturity of the prefrontal cortex and things like that, and a longer history of, um, addiction process in the brain. I would say maybe, probably, but everybody's individualized. And even when you take, they do these studies where, somebody who has, cocaine use disorder for 2 years, 5 years, 10 years, it's hard to correlate. Even if they took everybody had 10 years, you still see differences in a brain, and maybe they look like somebody who had it with 2 years. So, I mean, it's hard to say. I think that's a tough hypothetical question, but I always say everybody's individualized. So I've had people that are, just brutal and have such a severe disease that started when they were 31. It's like, and they come to me at 35, and it was off to the races because they had one click, one kind of, um, so.
And I realize you're not like probably a neuro guy, but it just so happened I was reading a thing on biofeedback last night. Because my boyfriend took his son who's autistic, had all the brain mapping done and everything, and I was reading all of the results. And I actually had a psychologist that I went to a couple of years back that specialized in biofeedback, and just sitting here thinking, is biofeedback an effective, sort of a co-treatment maybe with, um, medication assisted treatment for SUD, or is the brain so messed up that until the brain gets healthy again, maybe biofeedback wouldn't be very effective.
When you say biofeedback, can you give me an example? Like,
Yeah, this is, where they put the sensors on you, and they map and monitor your the brain's responses to certain stimuli, and then they can actually sort of predict where you're lacking in certain kinds of responses, like um, usually emotional responses. And so just sitting here thinking about that, it's like, well, we know that, SUD affects, actually affects the brain. And it takes a while after you're in recovery for the brain to go back to its normal state. And
mhm.
so I just wondered, it's like, probably biofeedback wouldn't be a very good resource for somebody who hasn't been in recovery for quite some time till their brain's back to quote unquote normal. I mean,
Yeah. Yeah, I don't know. I don't know the answer to that. I don't have any. I'm not familiar with. I've never used kind of biofeedback, so.
yeah. Well, it's that whole neuroplasticity thing that, okay, your brain teaches itself to do things in a certain way over time because of repetition, and so you can actually go the opposite way too, and
Sure.
and unteach it or reteach it. And so it's like, I wonder if that could work with cravings and stuff. I don't know, but
Yeah, it's definitely a good thought to think. Now, you'd have to have all the equipment and everything like that to do this, right?
right. I know
Well,
when I went to this therapist, I walked in his office and he had his machine there and all this stuff. I said, "Are you going to hook me up to that?" And he was like, "Not unless you need it." I guess
Yeah.
I'll find out. And he was big into, of course, mindfulness,
Yeah,
which
sure. Mindfulness. Absolutely.
right. And that's where that whole neuroplasticity thing. So he got me into the mindfulness and the meditation, which is another way of, reteaching the brain and doing that neuroplasticity thing,
Mhm.
without that. Basically, the biofeedback, it just, like I said, it measures those brain waves as I understand it. So it gives you a sort of a starting point to look at, and then to try certain things to see if it's working, if that makes sense.
Yeah, no, but I'm not familiar with anybody that's doing that, or I didn't train like anybody that was doing it, so I
Yeah.
don't have an answer.
Okay. What is your relationship there in Roscommon County? You, and I'm not as familiar, do you have like a hospital with an ER? And, does your clinic actively interact with the ER department?
So we have a health center, so we have just physician offices, and then we have an urgent care. Um, so I don't know. So yeah, we interact with the urgent care if they need our help or anything like that. Or if they need a consult or something like that, they'll call us, and I'll have my nurse manager go up there and provide resources or whatever. But usually, if any of our patients ever come in, they just come down to our office, and then so our whole bottom floor is the SUD clinic, and then this first floor is, I think we have one pediatrician, and then we have four primary offices, and then we have a rehab place for PT, and then we have an urgent care. So it's not huge, but it's nice.
So for us here in Kalkaska County with a county hospital, with an emergency room, if somebody came in, in an overdose situation, because we're constantly thinking about how do we get resources into people's hands? Could somebody that was a resident of Kalkaska County drive to Roscommon and be a patient at your clinic?
Um, yeah, I mean, a lot of our patients are not from Roscommon. I would say, people drive an hour and a half, some people to come to our clinic. So, yeah.
Right. Well, and I know we've got folks, that are on methadone and they drive routinely to Gaylord, to the clinic there. We have folks because Kalkaska is kind of a treatment wasteland, really, and pretty much to get any kind of ongoing long term, we do have one MAT provider, who actually is a counselor, and then he uses a prescriber, a doc that's all completely telehealth from another state actually to do the prescribing. But other than that, we don't have anybody in Kalkaska County. So you have to go to Travers, or we do refer a lot of people to Bear River, which so I'm always trying to think of, okay, try this, go here, go there, call here. Um, I mean, I wish we did have more. But I think part of that goes back to that stigma again. And even, when you look at Traverse City, which is another one of my counties, fairly progressive in a lot of ways and a little backwards in others. People have tried to open medically assisted treatment clinics and gotten pushback in Traverse City. So you said you have an affiliation with Bear River. I had heard at one point that they were going to lose their detox center because of some rules that changed about having to have a doc, either on site 24/7, and there was kind of a big panic or whatever, not too awfully long ago. Apparently that didn't happen because you said they still do have detox.
Yep, yep. The medical director for the detox is, I think it's Robert Smith. Um, so he's over there, but I didn't hear anything about that, as far as that goes.
Yeah, this was probably maybe 2 years ago, maybe a year and a half ago, where some state law or rule changed, and where you could get by with having a physician's assistant on site or whatever, during some of those off hours. Something changed, and both ATS and Bear River were kind of in a panic that they were going to have to close their detox center, which it's very, very necessary.
Yeah,
And
I didn't hear. I just signed on with them about a year ago, but from everything I've, Dan, in everything I've seen, they're moving forward. They're actually expanding tremendously. So, but yeah, I didn't hear any of that. But I could always look into that too. So,
Harbor Hall,
And
wow.
Lisa, it sounds like we actually will be adding some more providers there in Kalkaska. And speaking with
yeah,
Jeremy at Kalkaska Memorial Hospital, we're just trying to kind of nail down the specifics, but there's a number of physicians there in the ER and the primary offices there in the hospital that are looking to become waivered. And they're going to start an MOUD program there as well.
awesome. Well, and I've got my fingers in all kinds of pies here, and that's how so I'm so pleased to hear that. Very pleased to hear that.
Do we have a time frame?
We don't, I met with Jeremy maybe about a month ago. Lisa actually helped kind of set that up. And we kind of had Jeremy was going to go back, kind of identify which players are going to be involved. There's a group that had kind of said that they were very interested in. Right now, I just touched base with them about a week ago. Some of the docs were on vacation and just getting back in. So, we've got waiver trainings here, one April 8th and then again May 14th. So hopefully we can get them into one or both of those and then get it started right after that. He was also, I think, trying to coordinate with Paul Oliver there in Benzie County, because Benzie County is just very similar to Kalkaska County in many ways.
Right.
There's really providers there. The need is probably about the same in both counties. And Paul Oliver, Dr. Morrow is one of the county hospitals there as well. And I don't think they have any providers in Benzie County either.
Right. So Christina Eichenroth, who works for Munson and Travers, she had approached us a while back for support from the coalition for a grant that they were trying to get that had to do with the emergency room in Kalkaska. And it's like, sure, I'm willing to support anything that's going to get this county moving, but I haven't heard anything if it's, if they were awarded, and I wasn't completely sure what the grant was for. I just knew it was for increased SUD services through the ER. Did Jeremy say anything about that or mention it?
He didn't. He just is kind of the champion there of this, and he just kind of been slowly kind of talking to different physicians there at the hospital, trying to identify who was interested, and he got his blessing from above to move forward with it.
Oh, our fingers crossed.
Yep.
That's awesome. Yeah. So Dr. McMorrow, as far as success rate for your patients, do you do any kind of family education for the family members of the patients? And do you think that increases their success rate if the family's on board?
So I think it does, as long as the patient wants the family involved, obviously. And what I do is I offer them, I say, bring in whoever you want to be involved in your recovery, and I can talk to them. And so we hand out sheets about, the addiction process as a chronic disease, and I answer questions and try to involve their family members, because they're going to be the best support if they understand what's going on. So yeah, to answer the question, absolutely. And I think that really helps in some patients as well, because they'll, oh, well, my mom didn't even want me to come in here. Or I said, well, bring your mom. So I spent half an hour talking to mom. And after we talk, it's like, oh, wow. Okay, great. So.
Good. That's my feeling. We need to get the whole family involved if possible.
Yep. Mm-hmm. Yeah. Whatever support system they want. And,
I think supportive family and community makes a big difference for recovery.
Yeah, even the studies show the milieu of the office, just our secretary and our nurse manager, and people will say, I had one patient this morning say, this is my only appointment every month I look forward to, because they come in, the secretary's great, they get candy for their their kids, they want coffee, just that whole acceptive environment. They know it's a safe place, and they know they're supported. I mean, that's a huge, huge difference. So, and they're never judged, and they're never, judged or punished. There's no punitive for relapse. We try to do positive reinforcement. We hand out our own, um, our own tokens, for 30 days, 60 days, 90 days.
Awesome.
Yeah. So we're setting up a contingency management program to get back with the meth and the stimulant use to try to, hopefully improve on that. So,
With the you know, several years back, thinking about stimulant use, I had both a son and a stepson who were diagnosed with ADHD, and so we're on, and I can't remember, it was Concerta first and Adderall after, or one or the other. Anyway, all through school, and then both actually chose when they were about 18 to discontinue their medication. But do you think there's any connection at all between um, stimulant use as a kid and then later possible stimulant use disorder?
yeah. So there's pretty strong evidence that if somebody has a true ADHD as a child and continues it through adulthood and they're not managed properly, they will and can have a high prevalence to get a stimulant use disorder.
Yeah, that would make sense to me just because of the whole theory of self-medication that
Right. So I've had a lot of patients that have been on, these stimulants, they get into meth, and then I get them back on their correct, a Vyvanse or something, and
right,
they're stable as can be, and they take off, and they're wonderful. They say, finally, I feel normal. I'm back on my meds, and nobody wants to give them the stimulant that they're supposed to be on because they have
right.
stimulants, but they're have the stimulant use disorder because of their process that they went through before that.
Huh. Um, yeah, that's so something that is, one of those rumors that I hear quite often that people, and I try to explain this to my son, those that truly have ADHD, and of course, there's a lot of misdiagnosis because things, symptoms can mimic other things. I get that, but it doesn't go away when you're an adult. You don't grow out of it. You may find ways of managing it, but truly, I think that's just the way you are. So
Yeah. Yep. And a lot of people will get better once that, maturity of that frontal lobe, and then they'll develop, ways to cope behavioral wise. So,
right. Right. Well, and he, just I could see it. He wasn't a behavior problem. This is my son when he got diagnosed. It was the fact that academically he was losing ground. And that was why. It was the inability to pay attention and absorb. And the minute we started him on medication, his attention improved and his grades and performance in school improved.
mhm.
And he of course every side effects, and I think that's probably even with your SUD patients, some of the side effects of the meds. Do you get complaints about, well, I don't want to, for your SUD patients, I don't want to take this anymore because it makes me feel like this, or it does this to me? Are the how do you manage side effects?
Well, as far as like buprenorphine or, um, yeah, that's a good question. I don't get many side effects, and if I do, somebody will say I get a little swelling or I get a little nauseous. But what patients will do, they'll kind of work through that. They'll eat differently at a certain time, or they'll kind of manage it themselves, and it's usually transient, and it kind of goes away. So honestly, I don't get too many long-term side effects on something. Um, I'm trying to think specifically. Um, you see that more in methadone. We don't do methadone here, but some hyperhidrosis in methadone. You see a lot of distinct sweating that patients have a problem with. Some mouth irritation with the Suboxone film. Sometimes I'll switch up the to Subsolve or even the Sublocade. So there's a lot of the headaches sometimes, and the nausea. So we'll change formulations a little bit and tinker with things. So usually we work through it. I don't think I've ever had a patient that their side effects were so severe, knock on wood, that I've had to kind of stop their therapy.
Is it
Good.
safe for someone who might have an opioid use disorder and an ADHD to take both types of medication?
I'm sorry, Susan, you were breaking up. What'd you say?
Would it be safe for someone that has an opioid use disorder and is on something like Suboxone to use medications for ADHD as well?
You asked me, is it okay?
Yeah, is it safe?
Oh, safe. Yeah. Yeah, I think so. If they have, I have, a handful of patients that are on, their stimulants with Suboxone, and they're doing great. They have a diagnosis of ADHD, and, it's all about function and how they're progressing in their recovery. If they're not abusing, their stimulants and they've been on it and they're progressing well and they're, using their Suboxone and, they're moving forward, and, that's absolutely, it's safe. The problem you get into is when you're just treating everybody the same and you don't individualize treatment. Somebody, you put everybody on a stimulant and everybody, that's kind of not great practice. So, but yeah, if you take everybody in an individual and, kind of march down their history and do what's appropriate and manage them appropriately and responsibly, and make sure you're gaining ground in their recovery, I think it's reasonable.
What are your thoughts, or have you read studies about long-term medication-assisted treatment?
Sure.
Are there dangers to that? No.
So the ASAM guidelines just came out again with the statement that said that there is, I'll share this with you. There is no, can you see this?
Coming.
There we go.
There it is.
Yeah, where is it? Here it is. It's a minor revision. There is no recommended time limit for pharmacological treatment with buprenorphine. We know that patients who discontinue bup treatment should be made aware of the risk associated with overdose and especially the risk of death if they return to opioid use. We know that people that discontinue methadone studies, within a year, I think they'll relapse. I forgot the percentage. What was it? Sorry, I forgot it offhand. But so to answer your question, yeah, here it is. We know that coming off methadone, 82% relapse by heroin by 1 year. So we know that there is no time limit for medication for opioid use disorder. Similar, there's not a time limit for somebody who's being on hypertensive drugs or, diabetic drugs. And usually if somebody wants to come off, I work with them, obviously, but they have to really have a good plan. They have to be stable, and they need to have a compelling reason why they want to come off, because otherwise the stats and the studies show they have a really probability of relapse.
Yeah. That's the reason I asked that question, is that's kind of a urban myth that circulates still around a lot, that, oh, well, you're not going to be on this forever and you have to wean yourself off and yada, yada, yada. And it's
No, that's archaic thinking now. And we know that that's not the case. So.
And I kind of knew that. I just wanted to get it on the recording.
Absolutely. Absolutely.
That's awesome.
Yeah.
Well, we got a couple more minutes. Is there anything anybody else wants to mention or ask or say?
I just want to say thank you, Dr. McMorrow, for your candid answers, and you're so approachable. And I was just telling somebody the other day, my daughter is in the medical industry, and she actually educated me quite a while back that it's okay to ask doctors questions, and you don't always have to believe everything they say verbatim, and
Yeah.
you should ask them questions. So,
Yeah.
you make it very easy to ask questions.
Yeah, absolutely. And I appreciate it. I also say too, with addiction, we're still kind of not making this up as we go. I mean, we're learning so much every week, every month, every year. So there's a lot of stuff that it's okay to not know. But as we work together, I think it's great that we're moving forward. So.
So we should
That's
be-
another big thing that both Suzanne and I believe in, is that we got to get out of our individual silos and communicate. And so, I like your multifaceted approach, because really, if we're going to make progress, that's the way it has to be. So,
Yeah, absolutely. Well, I appreciate your time, guys. Let me know if you ever need anything, in Kalkaska area, or you want me to come up and, talk to anybody. And, if Tim or I needs to get up there and, present, or, whatever, because we know knowledge builds, changes in behavior. So,
well, someday we have plans for our coalition that, we want to have big fancy summits where we get all our wonderful guest speakers and get everybody together, but it's probably not for a while yet, but we will definitely keep you in mind. So,
Great.
Yeah, if you ever have any way to get in with the sheriff's department and the courts, we'd love to present with them as well. I
we're
know
working on it.
Yep.
I know that'll be a big beacon of change if we can get them on board in the community. So that'd be a great place to go.
We'll keep you in the loop, Tim. That's absolutely sure.